My name is Karen Constantine, and this is an example of a meta review of a patient cared for in a community pharmacy setting. Meet MC. MC is a 68-year-old female who entered a community pharmacy looking to obtain medication management services. Her main concern was reducing her pill burden. Specifically, she wanted to be able to discontinue her potassium supplement. She couldn't understand why friends of hers seemed to be able to recover from low potassium and stop their supplements, whereas she could not. Upon questioning about general health and wellness, she mentions she has been waking up, quote, too early with Parkinson's symptoms that were previously controlled. She finds she has to take her levocarb earlier to help with this. MC appears to use multiple pharmacies, so gathering all her details from her electronic health record proves to be a bit challenging, but it is pieced together that her past medical history includes Parkinson's disease, which was diagnosed July 2023, and functional dyspepsia, which was diagnosed sometime in 2022. Allergies include NSAIDs, for which she reports facial swelling and shortness of breath. She doesn't recall which anti-inflammatories to which she reacted, but the reaction sounds serious, so NSAIDs in general are to be avoided. MC has no primary care medical doctor or nurse practitioner. Her drug coverage includes the provincial drug plan. She is a retired fish plant worker and has achieved her high school diploma. She lives at home with her husband and her adult son, who both are disabled. No member of the family has a license or vehicle, so travel is difficult. MC denies use of tobacco, ethanol, or illicit drugs. This is a list of MC's medications in chronological order of prescribing. MC generally understands the purpose of each of her medications. She reported rabeprazole was initiated to treat reflux, which has resolved. She doesn't remember anything the doctor told her about her gabapentin prescription, however. The pharmacist who initially dispensed it told her it was for pain when she picked it up. When asked what type of pain she has, she describes it as an occasional diffuse pain across her back that seems to subside with rest and is worse after days she overexerts herself. She used to use Tylenol arthritis as needed prior to starting the gabapentin, and she recalls finding this very helpful. Her EHR, or electronic health record, displays no clinical note regarding her pain diagnosis, and she has no memory of the interaction that led to it being prescribed. The original prescriber no longer works in the province. When asked about Parkinson's symptoms, she says she feels quite stiff and shaky early in the morning and has been having increased difficulty getting out of bed, but denies feeling this way in the daytime so long as she takes her levodopa-carbidopa. She also finds she is waking up earlier to take her levodopa-carbidopa as a result of her morning stiffness. She reports furosemide is to control pedal edema, which returns when furosemide is discontinued. She uses the provincial telehealth phone service for her prescription renewals. We can see here that MC's potassium dropped below normal in February 2024, shortly after initiating furosemide, and it dropped again in December 2024 when she reported, if you look at the previous slide, having discontinued the potassium supplement for a few weeks prior to blood work. We also see her magnesium, ferritin, hemoglobin, and MCV are low as of approximately 2.5 months ago. She was thus treated with magnesium and iron for iron deficiency anemia. We see from this slide and the previous slide, she doesn't have any visible indicators of diabetes, chronic kidney disease, liver injury, or dyslipidemia. Although no EKG is visible on MC's EHR, as far as you can see, she's quite confident when you ask her that she has had one, and she believes within the last year, and according to her, it was normal. According to the slide, you can see in a report of an echo that was done and reported no abnormalities to indicate cardiac disease. And as previously noted, she started rabeprazole due to symptoms of reflux. And here we can see that in 2022, she had an endoscopy done and there were no signs of damage other than mild gastritis. During that endoscopy, a biopsy was performed. And we see on this slide, according to the pathology report, the biopsy showed no evidence of H. pylori, and the tissue appeared normal. This is a list of blood pressure readings, all from MC's Hypertension Canada approved home blood pressure monitoring machine. All blood pressure readings, both morning and evening, as well as her heart rates, are within target range. Her target for her blood pressure is 140 over 90, or less than 140 over 90 millimeters mercury. Given our lack of comorbidities, we could certainly shoot for a lower target to reduce risk of developing cardiovascular disease or events. However, the risk of hypotension and falls is more of a concern, especially given her current medication use, as well as her Parkinson's disease and her age. So, on to the drug therapy problems. So, polypharmacy seems to have claimed another victim. How does this happen? You wonder. Well, MC has no family care practitioner, travels from pharmacy to pharmacy and between the emergency room and walk-in telehealth services. Practitioners are treating symptoms but often have little time to delve into the root cause of the symptom. It's super important to have at least one primary care practitioner, so it's important to tell MC to make sure she sticks to one pharmacy. She finds this difficult as most community pharmacies near her are short-staffed and closing for lunch hours and we're open for shorter hours than before, including weekends. She has to visit the nearest pharmacy that is currently open. It's important to let her know that her prescription can be faxed. She does not have to pass it in directly, and it can be retrieved when pharmacies are open. So these are the drug therapy problems I've determined in the order of importance, in my opinion. So number 1, MC has hypokalemia and hypomagnesemia, possibly secondary to furosemide. MC is possibly experiencing gabapentin-induced pedal or ankle edema. Gabapentin may not be required therapy as pain may not be neuropathic, and what pain she appears to have is controlled and she does not report it as a problem. Number 3, MC is currently experiencing loss of control of overnight Parkinson's symptoms and may require a change in therapy. Number 4, rabeprazole is no longer required therapy as it was indicated for mild gastritis only or reflux symptoms. It may also be contributing to her hypomagnesemia or iron deficiency anemia. Number 5, MC has been taking ferrous gluc for iron deficiency anemia for 3 or more months and requires repeat CBC and ferritin labs to determine if therapy is still warranted or if a change in therapy is needed. So the 2 elements I use to determine the importance of each drug therapy problem would be number 1, patient concerns, and number 2, harm potential. 1 through 3 are clearly the top concerns, so risk of loop diuretic-induced hypokalemia being the most prominent concern, and increased risk of falls due to insufficient control of Parkinson's disease symptoms. I will only be developing a care plan for the top 2 drug therapy problems, so although I might want to put the drug therapy problem currently ranked number 3 in the number 2 position. Unfortunately, I can't address drug therapy problem 1 without addressing number 2. So this is my ranking for that reason. So the reason for ranking the first one number 1, it's well known that loop diuretics cause a decrease in electrolytes and minerals due to their mechanism of action. Hypokalemia is unfortunately a common side effect of these drugs, and as furosemide can cause hypocalcemia as well as hypochloremia, we should probably suggest blood work for these at her next appointment. But in my practice, these values often aren't ordered when patients are on furosemide unless they are hospitalized. Number 2, gabapentin is a known cause of bipedal edema, which we know by looking at the monograph. Even in young, healthy individuals, if you look at my references, there's a case report for a young, healthy male who experienced bipedal edema. And we've also seen elderly patients on doses as low as 300 milligrams a day. Again, there's a case report in my references. In addition, gabapentin is not first line for anxiety. If you look at the CANMAT guidelines for anxiety or epilepsy as a solo agent, if you look at the guidelines for Ontario epilepsy guidelines. So unless the goal for its use was to treat anxiety and pain simultaneously or perceived anxiety, given that she would have been having a tremor or probably some other symptoms of Parkinson's disease prior to it being diagnosed and treated. Gabapentin doesn't seem like the best choice for this patient, especially given the side effects she's experiencing. And the polypharmacy that resulted as a result of its prescription, or possibly as a result of its prescription, we need to hopefully resolve this. Seeing as how her pain is reported as mild to moderate at the worst of times, and that this was managed with as-needed Tylenol arthritis, she has no history of seizure, no complaints of anxiety. It seems reasonable to consider a taper of the gabapentin, and we will taper to avoid withdrawal, which we know, again, by looking at the mechanism of action of the drug and just reports in the monograph. MC is complaining of loss of control of her Parkinson's disease symptoms overnight, and she's taking her daytime dose of levodopa, first dose of the day, earlier as a method of combating this. She denies being symptomatic in the daytime, reports she can still manage her ADLs or her activities of daily living as she did before, and she denies any falls. So for this reason, I don't necessarily feel like this drug therapy problem can be ranked in the first two positions, but is obviously important to treat, especially as it seems her symptoms are progressing as her disease progresses. As we know, Parkinson's disease is a progressive neurologic disorder that requires periodic augmentation or adjustment of therapy as motor control worsens, so a change in therapy is required to reduce her symptom burden. And as we know from the systematic review by Connolly and Lane, adding a longer-acting agent is a good suggestion for someone who's having symptoms overnight as she is. For number 4, a literature review appears to demonstrate an association between PPI use and hypomagnesemia, and now the literature, there's lots of examples of this, of possible association from observation studies, as well as PPI-induced iron deficiency anemia. Since MC has had a sufficient period of PPI use to heal or resolve the mild gastritis reported in her endoscopy and also her reflux symptoms, she reports are absent, it would be a good idea to consider tapering to discontinue or PRI use. MC has been taking Ferrous Group for iron deficiency anemia for 3 months and should have had blood work to reevaluate CBC or ferritin by now to ensure values have returned to normal, to see if we need to continue for a little longer to make sure iron is or if we need to reassess therapy altogether. And then we can see this looking at the BC guidelines from India. So the plan for developed for the top 2 drug therapy problems. So an attempt to reduce MC's pedal edema and discontinue a possibly unnecessary therapy for gabapentin. I recommend taping her gabapentin by about 30% weekly as tolerated until discontinue. So the goals of this would be to avoid withdrawal symptoms, which could be confusion, present as confusion, irritability, tachycardia, sweating, or diaphoresis. And if any of these occur, taper can be slowed, stalled as required. And we also want to eliminate that pedal or ankle edema if possible. So the plan is for the pharmacist to call weekly to confirm that there's no increase in pain, to confirm there's no withdrawal, and to confirm that the edema is decreasing. If and only if the pedal edema resolves, we'll then discontinue the furosemide. And all this, of course, will be done in conjunction with a nurse practitioner or physician that she's in contact with using telehealth services. And the goal of this would be to resolve hypokalemia potentially, as well as to reduce hypomagnesemia, which obviously we need to, I think, remove the PPI to altogether resolve, but this will help obviously, and to avoid any increase in the blood pressure above her target. So follow-up and monitoring will include MC herself will monitor and record her blood pressure and heart rate as she was previously doing, so twice a day, once in the morning, once in the evening. And we, of course, will counsel on proper blood pressure technique. And the Pharmacist will call her in a week to monitor for recurrence of the ankle or pedal edema and to confirm that blood pressure is still in target range. So these are my references, and thanks for listening.